So let's start off with the biofilms in the dysbiosis. So this problem has a slippery slope that goes back to very likely childhood. And it starts off with essentially I suppose a lack of diversity and a dominance of certain species which produce biofilms, and they remain hidden in those biofilms because the immune surveillance can't see inside the biofilms. And these species are able to produce ethanol and/or acetaldehyde. And this is an important thing because the acetaldehyde has a key disruption of a number of very critical pathways. And now there can be multiple influences towards that. It can be vertical microbiome diversity loss. So if the mother's had antibiotics, she's lost bifido, lactobacillus, akkermansia, oxalobacter, a number of different species, then we're already going to be starting behind the eight ball. If the childhood has also had a lot of exposure to, let's say, fungal species, so if there's been like aspergillus or candida, and also strep, staph, klebsiella, various other species which are also able to produce acetaldehyde, H. pylori is another one, then yeah, what can happen is that the ability of the body to clear these particular species is limited because it can't see inside those biofilms. What it can do is deal with any of the cells which are outside the biofilm, so that if there's proliferation, if the whatever's going on inside the biofilm is now trying to grow or to seed another area, then the immune system is actually able to see those cells and inhibit that growth and that proliferation. However, if the immune system is distracted at the times where these events are going on, it's an opportunity for these biofilms to grow. And there are a number of things that actually cause the immune system to become distracted. We can talk about influenza, respiratory viruses, we can talk about childhood vaccines, we can talk about flu vaccines, we can talk about any antigen which ultimately has a capability of either triggering an interferon alpha response or causing a situation which reactivates a latent human herpes virus, which then triggers an interferon alpha response. So in this situation, there is, and it can be ear, nose, throat, eustachian tubes, any mucosal interface. And I think women are overrepresented in the syndrome or the chronic disease syndrome simply because they have a larger surface area of mucosal tissue. The men, we don't have a cervix, so we have a slightly reduced potential systemic burden, but it doesn't require large amounts of tissue to be occupied. I mean, you could have, as I was saying before, a tooth infection, and that might be sufficient to reach a point where we have, breakthrough infection, if you like, which leads into mild septicemia, bacterial or fungal septicemia. And this is enough to then trigger an innate immune response, which would then be IFN-gamma, which does some really interesting things. I'll come back to that. So before we get to that point, so we have these microbes which are producing acetaldehyde. We know that the acetaldehyde is going to inhibit aldehyde dehydrogenase activity because it has a higher affinity for that enzyme. So that if it was an enzyme that is, for example, degrading histamine, that pathway that's degrading histamine, if it's in a pathway that's producing carnitine, you might end up with rhabdomyolysis or something later. Problems with the carnitine shuttle and transporting fatty acids. If it's the B6 degradation pathway, then you'll see B6 toxicity. It's also, of course, in the catecholamine degradation pathways. And it turns up pretty much anywhere where it goes from some sort of monoamine or whatever, then through an aldehyde dehydrogenase, and then ends up as an acetate, the usual pathway. And there's a number of key places for that: vitamin A metabolism, lysine synthesis, the collagen synthesis pathway to proline. I'll show you all these, but it's in very, very specific places. GABA synthesis as a backup pathway as well from some of the polyamines. So what that means is that if we have acetaldehyde and if it's present as a gas in any of these mucosal tissues for any period of time, it ends up causing inflammation and lesions, which then, of course, allows those foreign proteins, the microbes or endotoxins, whatever, to be able to slip through the epithelium and then start triggering a mast cell activation and then ultimately, various innate immune response activity. So this is one of the mechanisms where we suddenly go from having dysbiosis to ultimately what could end up being invasive microbiome dysbiosis. And again, that's any tissue, not just the gut. So when the microbes are now visible to the internal, not the mucosal immune response, we now have the macrophages and various other things enacting their response. Interferon gamma appears to be the major innate immune response pathway for microorganisms. And what I might do is just switch over to one of the other ones, and we can step through that a little bit. I actually have a little interactive diagram explorer, which maybe shows this in a little bit easier, but I'll start here and maybe we'll swap over to that. So we have pathogen responsive to interferon gamma cascade. This promotes interferon gamma. One of the interesting things is that interferon gamma does things, but one of the things that it does do is that it actually alters the metabolism in a way that produces reactive oxygen species to oxidize pathogens.
Okay.
Really, really straightforward. It does that via promoting xanthine oxidase. So that basically takes purines, turns them into uric acid, and at the same time, it generates reactive oxygen species. When there is a presence of reactive oxygen species, that also triggers NADPH oxidase, so NOx to also be promoted. And then nitric oxide synthase is another possible enzyme that can be used to generate reactive oxygen species and reactive nitrogen species. However, that's also sensitive to some other parameters, some other cofactors like BH4. I'll come back to that. So NADPH oxidase is a particularly interesting one. According to the literature, when NADPH oxidase activity is elevated, it actually signals to inhibit mitochondrial complex 1, so NADH dehydrogenase. And that's a really critical thing, because if you are not metabolizing that NADH back to NAD as part of the citric acid cycle and the electron transport chain, you now have NADH pooling.
Right.
And that NADH pooling is really interesting because it then alters the flux through a number of these different enzymes, which are sensitive to the NAD to NADH balance, the pool balances. And so if it's a reversible reaction, then it potentially goes the other direction. If it's not a reversible reaction, then it might be inhibited, or depending on the way that enzyme's set up, it might actually then promote that activity. So where that gets really interesting is that there is another enzyme called NADP transhydrogenase.
Mm-hmm.
NADP transhydrogenase, what it does is essentially take NADP. It then uses NADH as a cofactor, and then it returns one NAD at the same time as making NADPH. So whenever interferon gamma is elevated, and the body does that in addition to when there's microbial invasions, it also does it in response to tissue damage and exercise. So it's actually part of tissue adaptation processes relative to exertion. It's also then responsible for all sorts of really interesting pathways, which we'll come back to in a minute, but particularly cholesterol biosynthesis and hormone biosynthesis. And also things like the methylation cycle, the BH4 recycling, collagen synthesis promotion, a number of other things. Whenever the NADPH pool level is elevated, then it then drives the activity of these reactions up. However, there are a number of different flow controllers and things which will then ultimately turn that on and off. So instead of, I would think of it basically as a pulse width. So it's whenever the NADPH pool level is elevated for a period of time, these things flow for a little while. As that comes back down again, those things slow back down again. So it's like pulses. Now, the problem then is that if there is a chronic signaling of interferon gamma because we've reached a threshold through all of these breakthrough infections through the epithelium, we now have a situation where the NADPH becomes elevated for an extended period of time. And the thing is that this will ultimately lead to a depletion of NAD. Now, there is a compensation pathway that also gets triggered during these alterations, these transcription alterations, which is essentially the tryptophan catabolic pathway through kynurenine, which then goes to NAD biosynthesis. So it gets upregulated as a compensation for the redox being inhibited. And this is all just part of the normal interferon gamma, transcription alterations. But of course, everything has a limitation. There's no free lunch. Something's got to pay the bill at the end. So eventually, that pathway is not going to work. You're going to run out of tryptophan, or there's going to be various other cofactors and things which you might run low, or there's oxidative stress. Various different things will run out. And so what happens is that cortisol ends up being used as the master negative regulator for the interferon gamma activity. So what happens there is there are a number of enzymes. I'll show you how that works. So purely at the cortisone to cortisol it's part of the metabolism. What happens is that when an NADPH, and I might just switch diagrams for a moment, show you that instead. Whoa, that's not the diagram I wanted. Sorry. So there we go. Okay. So when we're looking at, it's going to be friendly. Okay. So when we're looking at purely just a cortisone to cortisol back and forth. So when NADPH is elevated, it then drives cortisone into cortisol if the primary sex hormone isn't elevated. Right? So estradiol in females, DHT and testosterone in males will inhibit that reaction. So that's the controller. Then on the other side of that, if there's sufficient NAD, it will also drive it the other way from cortisol to cortisone, so it deactivates that. However, if NAD, becomes an issue, then basically cortisol is not going to get metabolized back to cortisone. So in this way, the primary sex hormone, which is also being synthesized in this pathway, ends up being a flow controller for that part of, that part of the metabolism. However, that's just the cortisone to cortisol. There is also the cortisol release, and that takes inputs from, again, NAD being low, P5P being low, and it then ultimately via the levels of phosphatidylserine. If phosphatidylserine ends up being low, it then causes the corticotropin releasing hormone to be elevated, which then also then promotes adrenocorticotropic hormone, which then basically alters a number of the other pathways here. It drives them up. It promotes everything that you see within ACTH. So it really pushes that pathway along towards ultimately the sex hormones and then eventually the degradation pathways that are also there. However, what you'll also see is these pathways. So we have the ones which are going sort of from top to bottom here, because they have a lot of in the first pathway from cholesterol, which then heads down into pregnenolone. These cofactors here, the adrenodoxin, it also, the reduced form, requires NADPH. So again, we have that flow controller here from cholesterol. So everything that is coming from cholesterol down vertically is needing NADPH. And then when we move left to right, we'll see that these HSD reactions, they require NAD, but they're also sensitive to magnesium, zinc, and we've got potassium and chloride. And so if we reach a point where any of the cofactors or the ions or whatever are low here, so if it's low NAD or any of those electrolytes, zinc, then we end up decreasing the activity from, say, pregnenolone to progesterone, or progesterone through to 11-deoxycorticosterone, or whatever it's going to end up being. The end result of this ultimately is that estradiol ends up being elevated, cortisol ends up being elevated. And so the ultimate effect is that then decreases the interferon gamma signaling, which then resets the whole pathway and then allows the metabolism to reset and restore. thereby replenishing whatever, pathway or cofactor that ended up being low. Now, if you then realize that this is then the NADH is being generated in relation to metabolic activity and exertion, that means that across a day, the levels of cortisol are likely to end up elevated in the evening. So you end up with an inverted diurnal cortisol release profile. So that means that you're more energetic and productive in the evening, but then your sleep is also thrown out and you end up with something like daily jet lag. Okay, but it's a critical thing. The interesting thing is the way that some of these metabolites, these cofactors, are actually sensed. I might go to the. Let's see what. So, for example, we talked about the P5P being something that is being sensed. So the way that works is if we've got transforming growth factor beta 1 being elevated, which gets elevated in response to tissue damage signaling, then what happens here is it inhibits these reactions here, PNPO, 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 which then means that if you like, the inactive form of P5P, so PNP, is not being as readily metabolized into P5P. So we end up low in intracellular P5P, generally at the same time as, for various reasons, an elevation of pyridoxal, and that's generally because the degradation pathway happens to be inhibited by acetaldehyde, and usually when we look at the minerals and some of the other metabolites, we see that the riboflavin metabolism ends up being impaired, and that's like if the thyroid's not working properly or there's low molybdenum, whichever, you end up in low flavin mononucleotide or bad as well. But yeah, so we end up with this elevation of B6, we end up with a decrease of P5P, and then that reduction of P5P ends up then inhibiting, of course, all the P5P related reactions, which is really annoying, things like the amino acid decarboxylase, the GAD, so converting glutamate to GABA, things like that, very, very important things. But ultimately here, from the sensing aspect of the cortisol, acting to regulate that pathway negatively, if we don't have glycogen / glucose, so if there's a lack of 3-phosphoglycerate, which then needs to go through this pathway, through another dehydrogenase, which is sensitive to NAD here, which then goes through another transamination, which is sensitive to glutamate and alpha-ketoglutarate, but ultimately P5P. Then via that pathway, we end up with that reduction of phosphatidylserine. So that then triggers the cortisol to go up, which then, of course, triggers all the things that you would normally expect to happen as the cortisol goes up. So it upregulates all the catabolic pathways. We end up with here we end up with PNMT and upregulating the production of epinephrine. And then, of course, the other parts are here. So we've inhibited glycogen synthase. We're ultimately trying to drive the existing glycogen into the glycolytic pathways that ultimately end up with pyruvate. But it's it winds up the catabolic pathways and resets the immune activity. So what we can end up then is if we have various different influences which are, let's call it, dysregulating this cortisol pathway, and there are a number of them, and particularly the glycogen metabolism and the glucose uptake. So if we've got elevations of cholesterol, and we know we do because of some of the things that are going on, I'll come back to that, but that's again usually acetaldehyde and ALDH activity. If we've got problems with the glucose transporters, if we've got low chromium and low vanadium, and that shows up all the time, not 100% of the time, but it shows up a lot in the mineral testing. Or we've got other issues with IFN-alpha being elevated, then yeah, GLUT4, GLUT2 might end up being, the activity might end up being reduced. So we have less glucose being picked up into the cells, and you'll see a higher level of serum glucose. Oh my gosh, that looks like diabetes, doesn't it? Oh, yes, it does. So we now have high cholesterol, and we have
and triglycerides through the roof. Yeah. Never had these issues before. And obviously there's the sympathetic overdrive, which just will not switch off. They all just make sense.
So we now have essentially a glycogen synthesis rate that might be, 1/10 the rate of the general population, we have elevated cholesterols, and we have a distinct lack of glycolytic energy availability. So that's actually one of the big inputs towards postural orthostatic tachycardia syndrome. And it also is one of the major inputs for, the inability to activate muscle tissue, to maintain the ATPases, to maintain the electrolyte gradients in the, in the extracellular fluid and the cells. So the muscle activation becomes a bit of an issue there as well. There are some other influences on the glycolytic pathway as well. While we're here, oxidative stress is going to turn off the PKM2. I mean, the major input is essentially if the glycolytic pathway is lacking that fructose 1,6-biphosphate, then that basically doesn't activate the pyruvate kinase. But yeah, if there are other things which are present, if you have aspergillus, for example, and you've got gliotoxin, that's another inhibitor for that pyruvate kinase. If you've got lead poisoning, if you've got, interestingly enough, if you've got PKU, and you may, if you run low on BH4, which is what's going to happen when the vitamin C runs out, BH4 ends up getting used as an alternative antioxidant, as does B12, as does a number of other things, melatonin, blah, blah, blah. Then you might end up with an elevation of phenylalanine. And so that's largely because the phenylalanine hydroxylase activity is going to be inhibited by the lack of BH4. So with that elevation, you can then end up inhibiting the glycolysis pathway at PEP through to pyruvate, and you end up in the same mess there as well. So ultimately, the glycolytic pathway is now fairly heavily impaired, sometimes more than others, and you see that in the organic acids tests when you're actually doing we use the Great Plains or the Mosaic Diagnostics oat. It's a really good panel to actually see most of this, and we use a separate mineral test, which is a really unusual one.
I've had that. I might send it to you, actually.
Yeah, that would be really interesting. I'll give you a breakdown of that. And then, while we're over in this section, you can see if P5P is low, so we've now lost a backup pathway of tyrosine through to tyramine. We've also lost L-dopa through to dopamine, or at least reduced them. And the normal pathway, which is the one which is controlled by histamine being elevated, that'll inhibit it. So it's tyrosine hydroxylase, and it's also driven up by cyclical AMP and protein kinase A, and of course it needs calcium and potassium. Tyrosine hydroxylase ultimately is the regulator for the dopamine synthesis, at least one of the main ones. Actually, while we're over here, I'll just touch on something really, really quickly and really, really interesting. So when we have that acetaldehyde toxicity, and we have these aldehyde dehydrogenase reactions being inhibited, and this, of course, also relates to the interferon gamma activity being elevated, what's really interesting is we actually have an endogenous pathway for morphine biosynthesis. So it takes dopamine and it takes an aldehyde metabolite of dopamine, and it goes down another pathway through to protein and morphine. So it's not going to be huge levels of morphine like you would use in theater or something, but it does mean that when you start correcting some of these inhibitions, you then go through a mild-ish amount of morphine withdrawal / tolerance symptoms. And of course, they look very similar to a lot of the CFS or long pollen or long COVID or whatever you want to call them issues. There's actually, just while we're on that topic, the same thing happens with GHB. So when there is an issue with the ALDHs being inhibited, then that other aldehyde from GABA, which then can come back into the citric acid cycle at succinate, then, and also upregulated by NADPH, gets driven into 4-hydroxybutyrate, so gamma hydroxybutyrate. And you see that in the OATs as well, is that Marcus 75, I think it is. So you can end up again with tolerance and withdrawal symptoms to chronic GHB. Anyway, interesting stuff. Now, I've gone off on a tangent, and maybe I should get back to some of the primary parts of the metabolism, or at least the alterations. So we've got a dysregulated interferon gamma response, so which means that it's not always able to maintain the inhibition of these invading microbes. We also have, from the inflammation, we have mineral transporters that are being inhibited by hepcidin being promoted by a handful of cytokines, TNF-alpha, IL-1 beta, IL-6, IL-10, IL-22. When they're elevated, it then promotes hepcidin, and then hepcidin shuts off or inhibits divalent metal transporter 1 and ferroportin. And that's mainly known in the literature as being the master iron homeostasis regulator, which makes sense. I mean, if you've got an invading pathogen, right, you want to remove the minerals out of circulation so that the invading pathogens aren't able to proliferate as well. So it locks up, it sequesters the iron, and as it turns out, 8 other elements in certain cells in the kidneys, the liver, and the brain. And presumably that was intended to be a short-term response. And then, hopefully whatever else is happening with the adaptive immune response and, the various activities going on, that, the pathogens are gone, the inflammation's gone, and the metal transport has now resumed. However, when it's been chronic for a long time, because the other cells which also have these transporters, the DMT1 and ferroportin, also includes the cells in the gut. And what's interesting is those cells. Some cells, they have DMT1 and ferroportin. That's the ones in the gut. Some of them just have ferroportin. So the brain, the liver, and kidneys. It means that it still transports the metals into the cell, but when hepcidin is elevated, it turns off the transport out of the cell. So they accumulate those metals for that period of time. So yeah, very, very interesting.
So I'm high in gadolinium and lead.
Yep. Yeah, I'm sure a couple of
MRIs. Four MRIs, which kind of makes sense with the gadolinium.
Yeah.
The lead, I honestly can't figure that one out, because unless I was drinking out of lead pipes as a child when we lived abroad, I can't imagine where that came from. But this explains.
Well, I can show you something really interesting here. Silicon turns out to be really critical.
Right.
So silicon, as far as I know at this point, isn't transported by DMT1 and ferroportin. I think it's actually transported mainly by the AQP enzymes. These are 579, I think, mostly. Silicon actually gets used to form adducts with various different toxins, acetaldehyde in particular. It's not really mentioned in the literature much, at least in vivo. However, it's used extensively for HPLCs and things. And it happens at room temperature, and it just spontaneously forms. So there's absolutely no reason why it wouldn't be happening. And it does this also with a number of other heavy metals and things like that. So if you have a deficiency of silicon, which you will if you have this chronic production of the acetaldehyde, and of course, the ALDH enzymes and things are not keeping up with the load, then you end up low silicon. And you see that in the urine. So when we've measured urine silicon, you see an elevation simply because it's being excreted as part of this, this detox event. And why that's also important is because once the silicon is depleted, your ability to chelate a number of these other heavy metals, and you see that with cadmium, you see it with silver, you see it with mercury, you see it with lead, tin, ends up being decreased. And it's not just silicon that can also do this. You see the same thing with zinc and chromium and a couple of the other metals, depending on what adducts it forms. But you end up sacrificing these different minerals as an alternative route, or maybe it's the primary route. I don't know. There's also various things with the glutathione pathways and things like that, of course. But yeah, these adducts are a way that these things are able to be safely removed from the body. So what that means is if you've been carrying on with this dysbiosis and this acetaldehyde production, and of course, if you happen to drink alcohol, this is another additional input into this load, you are ultimately over time going to be decreasing your silicon stores. And that turns out to be a really, really critical thing. So in addition to your, lead, one of the things that's really interesting is when we talk about the reactivation of these human herpes viruses. So hypoxia-inducible factors 1-alpha, which is a signaling protein which senses via the activity of the prolyl hydroxylases. It senses for hypoxia, so the lack of oxygen. It senses for oxidative stress, because it requires vitamin C. And it also is sensitive, because of the way that those enzymes work, it's sensitive to ferritin levels when simultaneously the silicon levels are low, depending on the cell. So at the time that the body's actually kicked out the iron, so it's sequestered the iron into the brain and the kidneys, or if it's been chronically low because of this chronic anemia of inflammation, then the silicon is supposed to be stepping in as a backup ion for those enzymes. And of course, if you're low zinc, then those enzymes aren't being stabilized either. So the prolyl hydroxylases then become hypersensitive to these fault conditions. They're also hypersensitive, of course, if there's not enough substrate for those reactions. They're also sensitive if the succinate levels become elevated. That actually inhibits the prolyl hydroxylases as well. And that's actually also important because the other immune response pathway, there's type 1 interferons, interferon-alpha, they, via attacchinate production, end up inhibiting succinate dehydrogenase. So if there's an issue with riboflavin metabolism, if there is an issue with interferon-alpha being triggered, which can also be some of those microbes, so anything that, while we're over here, anything that has isocitrate lyase being expressed, which is quite a number of different species, that actually triggers an interferon-alpha response and attacchinate production. And I can see a logical reason for it to do that too, because ultimately what it does is it shuts down succinate dehydrogenase. And so isocitrate lyase, it actually like short circuits the Krebs cycle and produces glyoxylate as one of the products. So when the body responds to that, what it does is it shuts down succinate dehydrogenase, increases the levels of succinate, decreases the gradient across the reaction, which then basically shuts down the energy production for those microorganisms. Pretty smart, right? And of course, the same mechanism, if you're dealing with a viral infection, shutting down the Krebs cycle of succinate dehydrogenase is another way to reduce the proliferation rate, of course. Okay, easy. So it's essentially an energy inhibitor.
Okay.
The usual story, though, if you shut... Yeah. But yeah, if you shut down complex 2 or succinate dehydrogenase, that means that part of this bad redox is going to be reduced. There are a number of other enzymes which also act like complex 2, and maybe this is a good time to touch on some of that. So when these immune pathways are activated, so we talked about interferon-gamma shutting down complex 1, interferon-alpha shutting down complex 2. However, those enzymes on the inside, the inner membrane of the mitochondrial matrix, they're not the only ones that act as electron donors, if you like. And what's really interesting is if you have a look at this enzyme here, so this ALDH here, it is it converts glutamate through to P5C, so pyrroline 5-carboxylase, which then can go down through another reductase into proline. And then from proline, it can go through the collagen synthesis pathway. It depends on how much activity you've got there. So if we have an excessive amount of proline being generated, it may well be at that time that it gets driven back up to P5C and goes to glutamate or anywhere else, up to ornithine or somewhere else altogether. But these reactions, so the proline dehydrogenase and down here from hydroxyproline dehydrogenase, they're actually sitting on the inside of the inner membrane of the mitochondrial matrix, just like complex 2. So their activity as part of that collagen synthesis pathway actually drives ATP synthase. And it's actually not the only one. Much like in the microbial metabolism, we also have another oxidoreductase here as part of the hydrogen sulfide through to thiosulfate. So yeah, and you see this being upregulated, the sulfate production, when you're looking at some of the data. So we have essentially alternatives to complex 1 and complex 2, and they appear to be upregulated during immune activity. And this kind of explains a number of the different things. It also makes sense too, because if you're dealing with a microbial infection, then chances are it means that the microbe has probably come through some sort of impaired barrier. So you would actually want a collagen synthesis pathway to be upregulated as part of that immune activity. So you can see a benefit from that happening. But of course, here's the kicker. Here's the kicker. So while it's supposed to be getting driven up by NADPH being elevated and interferon-gamma, it's an ALDH. So that acetaldehyde inhibits the proline synthesis. So that's one of the amino acids that we need for the collagen synthesis. Not shown on this diagram yet, will be soon enough. Lysine biosynthesis also has an ALDH step, I think 1 or 2 reactions before we get to lysine. So we have we don't have enough proline, we don't have enough lysine. And then depending on the state of the minerals, we might have an issue with bromine, zinc, copper. And of course, if there's an insufficiency of ATP, then there's a number of reactions in that protein synthesis pathway, which I haven't shown. So that's a collagen synthesis. And then we've got the degradation pathway, and that's actually being driven up under certain circumstances, but the prolyl hydroxylase activity is also going to be creating a problem there. So we end up with the collagen degradation pathway potentially being either driven up or driven down, but ultimately we end up with a collagen synthesis or collagen connective tissue disorder. So that's yeah. And just in case that wasn't enough, hydroxyproline, that degradation pathway ends up feeding back into the glyoxylate. So depending on the state of hypoxia-inducible factors, 1-alpha, and depending on the level of P5P, if when hypoxia-inducible factors 1-alpha is stabilized, it actually increases the lactate dehydrogenase. So it promotes glyoxylate through to oxalates, rather than going via those transaminations to produce lysine. So that's a very interesting one. So this pathway being problematic is likely going to end up with more oxalate production, endogenous oxalate production. There's a link back from here back to the microbiome as well, because there's actually I don't think it's been studied well enough, but the Oxalobacter formagenes, it has some sort of microbe to host signaling where when it's present, the oxalates which are circulating end up being excreted via the GI tract rather than the kidneys. But if that microbe's not there, then it defaults back to renal excretion. So you end up with the kidney stones. Some of the lactobacillus species, they have those enzymes. They can metabolize the oxalates in the same way that Oxalobacter formagenes does. But I am not sure, I don't think the literature is clear on it at the moment, that they actually have that same signaling to the host. So I don't know. It's something I hope to find out soon enough. But yeah, so part of the lack of microbiome diversity, it means that your oxalate metabolism is going to be impaired, which means you end up with oxalate crystals, and that can be sore muscle tissue, whatever, but also kidney stones and everything else.
Which is why food's high in oxalate. Beans and stuff. Yeah.
So yeah, so you can see how this is starting to hang together. I'm pretty sure. There are other things that happen too. We could look at a number of different things. We talked about before the tryptophan catabolic pathway, which is then upregulated by the IFN-gamma. I mean, I'll just quickly, sort of go through that. We can see that ultimately it ends up down here at NAD. Oh, and aspergillus, worth a mention. If you have aspergillus as one of your pathogenic microbes, which are in abundance, they actually express NAD kinase on the outside of the cell, which then, of course, increases the bias of the conversion of NAD to NADP. So this then further exacerbates that metabolic alteration, which then further increases the metabolism of NADP to NADPH and leading to a reduction of NAD. So you run faster into that cortisol elevation just simply by having the aspergillus. Very interesting.
Yeah, I mean, the thing about this is that obviously there's lots of people who are working on different parts of this. And there's people who are saying, okay, right, let's address the magnesium. There's people who are saying, let's address, I don't know, it's this actually brings everything together.
Right.
Address sympathetic overdrive, address the histamine. And the reason people, I think, derive temporary benefit or partial benefit from those things in most cases is because everything's just linked, and it's that needs to be dealt with. So yeah, I'm finding this absolutely fascinating. I must admit that my biochemistry knowledge dates back 30 years. I mean, that's the first year med school was when I studied biochemistry, not after that. But yeah, from a clinician's perspective, it does make sense that there can't be 20 different processes going on that are just
No, it's exactly right. And it all, you can see how it all links back to this, the innate immune response being activated, plus the presence of that endotoxin, the acetaldehyde.
Yeah. Can I ask where alpha fits into this? Purely because mine is ridiculously elevated. Like the upper limit is 8 or something picograms per mil, mine is 500. Is it just a signal, or does it have a part to play in this?
Sorry, I missed that first part. Which is the metabolite?
TNF-alpha.
Oh, TNF-alpha. Yeah, so it's an interesting one. I've been actually trying to think about this one. The TNF-alpha, I mean, it does a number of interesting things. We talked about that one with the GLUT4 being inhibited.
Yeah.
I actually wonder, and I need to actually study this because I haven't. I only thought of this the other day. Is there a benefit? Do any of the microbes also have their glucose transport inhibited by TNF-alpha? I need to actually ask that question. I haven't looked it up, and I am curious. It also then inhibits the mineral, transporter, the hepcidin, promotes the hepcidin increase. It also does a number of others. If it's elevated, then yeah, you are very likely dealing with a microbial infection, which would be totally unsurprising at this point based on what we've seen so far.
Yeah.
It's
and my gut flora is very much sort of high pathobionts, low akkermansia, and low bifido. It's a very typical pattern.
Well, the low bifido is another thing because the bifido is actually capable of metabolizing the acetaldehyde. So it can reduce some of the load and some of the damage to the epithelium. But if you're low bifido, then yeah, you've lost that layer of resilience there as well. Now, and there's a huge problem in trying to get bifido and some of these other non-spore forming microorganisms to recolonize, and that's the stomach acid.
Yeah.
So, yeah, the rectal route via probiotic enemas, retention enemas, I think is probably the best option there. According to the literature, it seems to have a similar efficacy to FMT, at least as far as getting the colonization done.
Right.
There's still things that need to be done with the biofilms, and that's kind of one of the really big issues in all of this is actually how you deal with those biofilms. And not every biofilm is the same, so you need different biofilm creators depending on circumstances. I suppose while we're out here, I'll come back to the microbes. Carnitine biosynthesis, you can see that there's other end. Methylation, probably a really big one. Actually look at. You know what? This is an older version of the diagram. There is also, again, when we're talking about aspergillus, it also has which one is it? Aflatoxin B1. It inhibits the cholinesterases. So you can end up with an elevation of acetylcholine, which of course leads to cognitive issues, head pressure, the muscle activation issues, or sort of pseudo paralysis type metabolism, and it's simply from the acetylcholine being elevated because of the inhibition of the cholinesterase. Anyway, while we're down here, so dietary choline or biosynthesis, whatever, through to betaine aldehyde, yet another ALDH, and then of course we end up with a deficiency of thymethylglycine or betaine. And of course that's going to be problematic for things like stomach acid production potentially as well. But it will inhibit our potential availability towards glycine, so we have yet another input towards the collagen synthesis issues. And if there's any zinc deficiencies, you can see how the methylation, all of these reactions here, so like methionine synthase, DHFR, which is converting BH2 back to BH4, part of the folate metabolism, and you can see that's upregulated again by that interferon gamma activity. So the pool, when NADPH is elevated, drives the activity on. MTHFR, I expect that everyone's got the MTHFR mutations in this.
Yeah, I have one. I have a polymorphism, yeah.
So again, if we look at this, it's really interesting. You talk about these mutations and you might say, okay, well, you produce 30% less of the MTHFR protein. Yeah, no problem. But while the interferon gamma pathway is being elevated all the time, that reaction is now only working in one direction. So we now have 510 MTHF being metabolized to 5 MTHF. not the other way around. So that means that if we've got another blockage here, if we've got problems with B12 availability, and that might be relating to riboflavin metabolism and things as well, or the oxidative stress, or we've got acetaldehyde inhibiting methionine synthase, we're still going to end up running into problems with the folate metabolism and the methylation. Again, that issue with the zinc here, cysteine to methionine. We get to issues where we have low SAMe, and of course with low SAMe we have 200 plus proteins which have not been produced very well. So the methylation is a critical piece of the metabolic cascade here in some of these alterations. Anyway, what else could we touch on? Any questions at this point?
How does this interact with clotting? Or
okay.
Because I know you mentioned obviously the endothelial dysfunction, which
so there's a few things.
The clotting abnormalities, but the reason I ask this is because it does appear, at least anecdotally, in people who have had long COVID for not very long, so like a few months, 3-4 months.
Mm-hmm.
If you treat the clotting, then there are people who are recovering baseline, and I just wonder whether that's because some of these processes haven't had chance to become embedded, and once you restore tissue perfusion,
then you might be able to restore the barrier function and
exactly.
Yeah, I think it's a lot of that. We were using, for example, N-acetylcysteine earlier in the game, and it was people, and it was largely the C19 vaccine injuries. If you got in early enough, high dose NAC for probably even 3 weeks, 2 to 3 weeks was sometimes enough to pull them out. I mean, NAC's going to do some extra things because it breaks the biofilms as well. It will deal with the clotting. It will deal with a number of different things. That was really good in the early days. But of course, once you've been in this cascade, in this loop for a while, you've now got the mineral deficiency. You've got all the support for the pathways, and it's too late. You've now got 50 fires to put out instead of one.
Oh, agree totally. I mean, I just keep forming them. So I've been more or less on triple anticoagulation since, for the past 2 years. And every time I come off it, the clots form again. Which is, surprising.
Well, think about it from a barrier degradation.
Sorry to interrupt, but what do you think about, because obviously there's a lot of people who are very devoted to SARS-CoV-2 persistence per se, I'm not so sure that in itself is a pathogenic factor.
Yeah, I think it can happen. And look, if there's still spike protein production from any source, then we still have an input towards the amyloid-like proteins being generated. And of course, look, we can test for it. The InCell DX test, of course, looks for the spike protein and the monocytes. That's actually pretty good. And of course, if you do have this ongoing issue from that, you're also running an additional risk towards the viral reactivation, like the HHV reactivation.
I think that's what's causing the symptoms rather than the spike itself. And I don't think it's SARS-CoV-2 persistence itself. I mean, it's there, but whether that's pathogenic, I don't know. I think it's the spike. I think a lot of people from the vaccine. Which is,
you've seen Kevin McKern's work?
No, I haven't.
And there's another professor in Japan, and what is it? 30% of the lipid nanoparticle contents, according to them, is plasmids. So as far as not needing, reverse transcriptase or line 1 or something to integrate the RNA, it's not needed. You've got a lipid nanoparticle that's going to transport those plasmids straight through the cell membranes and straight through the nucleus. The thing is, of course,
it's scary. It's really scary.
It is. But, I mean, look, from an optimist viewpoint, a few things there. So the cell has to undergo mitosis before it's going to integrate that. That's the first thing. So what that means is that any of the cells sitting on the barrier of the tissue, which are exposed then to the circulation, they're likely going to not be undergoing mitosis. They're going to be getting replaced from the cell behind or the side. So we then are potentially limiting the cells which have integrated that code probably to the localized injection site more than anywhere else. There probably still could be some, potentially some other cells, but I would say it's a lower rate for that. And you're still going to have, thanks to the T cell response, if they see those cells expressing those foreign proteins, they're going to treat it like it's infected with a virus. They're just going to kill them off anyway. I mean, too bad if it's cardiac cells, but they're still at least going to get eventually removed. So I think in the long run, and I've seen, Intel DX tests where they have been 15 months after, say, like a Pfizer shot, still producing spikes and never had COVID for that matter. But then after a certain amount of, intervention, they'll be fine. You can check them 6 months later, and they won't have any signs of ongoing spike. So, in the overall picture, I think you can treat these events like the viral, like any respiratory infections, whether it's SARS-CoV-2 or other things. You can treat them as catalysts, and you can treat them as events that push somebody who is already dealing with this dysbiosis and these biofilms further down the slippery slope and eventually off the cliff. So it's, I mean, the same thing happens if you look into similar syndromes. You've got things like the post-SSRI syndromes. You've got post-finasteride syndrome, post-Accutane syndrome. You've got a number of other things like Gulf War syndrome. You can have a chat again about the vaccines and things. We could also talk about how if we look at somebody's OAT and mineral markers and things who are on the spectrum, that they also look exactly the same.
When you say on the spectrum, do you mean neurodiverse?
No, autism spectrum disorder.
Yeah. So I mean that makes sense because it's the same issue, recognized sort of association. I was wondering about fluoroquinolone toxicity and Lyme.
Same problem. So look at if you look at the floxed population, one of the other things that the fluoroquinolones do is that they promote fungal bloom. So if you go and interfere with the microbiome even further, right? Antibiotics are probably one of the biggest issues in all of this.
Yeah,
hugest issue. Like we take, you stubbed your toe. Here you go. Have Cipro. Oh, you've got some acne. Have some doxycycline. No problem. And then the problem with this, of course, is that in the process of fixing up a localized infection, you've just gone and systemically destroyed the microbiome diversity across any of the other tissues. And if it's something in the large intestine they actually wanted to keep and it wasn't spore forming, you now are going to run into problems in trying to get that population back. If it's completely wiped out, it's a huge issue. But there are other modern life influences around that as well. It's not just the antibiotics. We've got the the issue that we preserve all our food, to keep it fresh on supermarket shelves. We cook our food. Where are the sources of the microbes that we're supposed to be replenishing our, and maintaining our diversity? So it's just non-existent. And then if we're living inside our, our houses and flats and things like that, and we're not getting out to nature all the time, essentially all we're doing is just amplifying the signature of our own microbiome back on ourselves. So whatever the most fittest species are that we're trailing everywhere that we exist in our habitat, the fittest species are going to end up being the ones which are dominating our own microbiome. It just becomes a negative feedback loop or a positive feedback over time. I think it's also really interesting that when you look at the markers and if you look at the symptoms that we're discussing here for long haulers, long COVID, CFS, it looks exactly the same as an 80-year-old or a 90-year-old or somebody who has the postural issues, the collagen synthesis disorder, the high D-dimer, the high lactate dehydrogenase, the cholesterol elevation. They've already been put on the statins and the beta blockers and all the rest of it. It's exactly the same. There's your glucose metabolism issues. I have all sorts of questions around that. Like is aging actually just a slippery slope that we're just pushed along by this dysbiosis, or is it accelerated by it? And what's our natural lifespan without these influences? What happens if we turn all that off? If we treat
one does wonder
80 like they're a chronic fatigue syndrome patient, what happens? I actually would really love to study that. So it's definitely on my to-do list.
Have you? I mean, I'm sure you're keen to publish this. Have you had any sort of?
Oh, I haven't finished the manuscript at the moment. So what I have been doing is just putting up my diagrams and things, and you know, assigning DOIs to them. So at least there's record of where it's come from. But yeah, I need to finish off the manuscript. I've just been so hands full with managing people.
Have you reached out to any of the ME scientists, or are you going to do this on your own?
Well, I'm part of the OMF group, the CFS working group. So I've been chatting with Ron and Rob about it on and off, and a few other people. So yeah, look, Ron's aware of a number of the things that I've been working on, and he's helping with some things as well.
Oh, that's good. Okay, yeah, I just wanted to, because this needs to get out there. And,
well, this is just it. We're at the point now where it's all a bit exciting and it's all starting to blow up. And places like Twitter, Gemma's done some wonderful things there.
I know,
and I haven't been the influx of people. You know, I was quietly just beavering away there, trying to get all the pathways mapped out and try to get it ready for scaling because
Okay.
Anyway, but here we are. So you just bite the bullets and play the cards you dealt.
Yeah. I mean, if you I mean, it sounds like you've got your collaborators, but if you were looking for other people, if you needed like a different platform or set of collaborators, I'm sure that Doug and Ricia would be interested. We're actually writing a review of ME-CFS at the moment. I mean, it's less mechanistic. It's more sort of, the downstream pathophysiology and the, the clinical features, treatments, etc. But, if you hit a wall, then I'm sure we'd be happy to collaborate on this with you.
Oh yeah, they'd be more than happy to have that discussion.
Okay, I'll actually, if you don't mind, I might just send them the Zoom. So are we done with the pathways and onto treatment now, or is there still some left?
We could spend probably another 3 or 4 hours on the pathways, but maybe we could.
Yeah, I'm not sure my brain could sustain that right now.
Yeah, I will. Maybe is there anything else worth touching on? Look, long story short, going through these logical steps, you can see basically we have the collagen synthesis degradation, disulfiram effect, anxiety, intolerance, dysfunction, increased cholesterols. Oh, I didn't touch on that. Renal dysfunction.
Yeah, got them all. Yeah.
So a number of different inputs to the renal dysfunction, other than the additional toxin load that it needs to deal with. Part of that interferon gamma cascade and the NAD and NADH, the NADPH, not dysregulation, alterations, is that it drives up a number of the P450 enzymes. So CYP2D6 is one that I mentioned here, 304 is another one to discuss. There's all the others that also needs to be discussed as well. Vitamin D, metabolism, 1-alpha hydroxylase, we could go into that for a very long time. CYP2D6 is worth mentioning, not just from drug metabolism angle, because 2D6 is obviously going to be quite critical if somebody's on one drug or polydrug scenario. When you start correcting the NAD alterations, and I can show you how we do that at the moment, then it means that if somebody's dose might be effective, what the circumstances are, suddenly it will either become more potent or less potent. So some of these things like Effexor, probably one I'd mention, if they're on opioids, some of those will also, the metabolism will be altered. But,
you know what, Josh, what's really interesting is I was on sertraline quite a high dose, 150, and I decided that I was just going to wean myself off it, partially because I'm keen to try psychedelics. I mean, I am microdosing, but I wanted to sort of try a high dose. And obviously you can't really do that when you're on SSRIs.
Well, no, you would have a very interesting problem with serotonin syndrome.
Exactly.
You may think on your metabolism, you may or may not respond to psychedelics. If you are responding to microdosing, great, then you've tested the waters. But yeah, some of the metabolic alterations around this will inhibit the
But something I've noticed just in the past few days, I got down to 25 of serotonin, which is like a tiny dose. I am feeling so much better.
Funny how that works.
Yeah, I know. I mean, just my heart rate, my HRV, my orthostatic tolerance.
Okay, so bear in mind that almost all of your symptoms are being generated by the interferon-gamma activity.
Yeah.
So if you are not maintaining the serotonin pathway, and it's one of the ways that you can kind of help reduce the load, if you like, on tryptophan, and then allow that NAD biosynthesis pathway to work is by being on some sort of SSRI, effectively. So if you are making less tryptophan available, then it means that you're going to have slightly more cortisol, you're going to have slightly more energy, you're going to end up reducing that interferon-gamma activity, and you're going to have less symptoms. So it's, unfortunately, the road home is going to involve you being quite sick. There's no real way around that.
Okay.
So it's, yeah, don't want to be the party pooper, but yeah, reducing the immune response, you will definitely feel a lot better.
Yeah, no, I mean, the thing is, I've plateaued, so I need to come out of this plateau.
Well, the other thing with all of that is too, they're just hacks. They're just patches for things. They're not doing anything for the root cause. And it's, you would say that there may be sometimes, appropriate under some circumstances, but it becomes just another patch that you've got to wean off and manage in the process when you start stabilizing the metabolism. And that's, yeah, anyway, it's just part of the journey, I guess.
Yeah. I'm just amazed that you put this together. It's just, yeah, incredible. So,
a bit of work.
Yeah, a bit.
But yeah, it's just like all these different things that are mapped. And there's more things that I'd like to include on this, but essentially you need to treat the disease as microbial-induced scurvy and alcoholism. I mean, that's essentially it.
That's a good analogy, yeah.
But then, yeah, dealing with the extra biofilms and the rest of it.
I mean, I tried serapeptase for the biofilms, but, it wasn't particularly effective.
Excellent. So this is something we're constantly working on and updating and improving. You'll see that it actually mentions
everything,
quite a wide scope of named diseases and syndromes and disorders. And those are just the ones that we've been able to get data for. And I suspect that we're going to see the same metabolic cascade present in quite a number of other things. Anyway, I'll move along. I won't read through all 30 pages or anything, but I'll just give you a little outline. In fact, I might even skip through some of the things. So one of the first things, the lymphatic system. If I was going to design the lymphatic system, there were a few things that I would do slightly different. So unlike the rest of the circulatory system, of course, there is no pump. The other thing is that there is a single point of failure with the thoracic duct. So under certain circumstances, such as a reduced activity level, because you're really sick, your energy metabolism is being inhibited, and the situation has been ongoing, then the lymph nodes end up getting blocked with all the extra debris, and yeah, you can end up with not just lymphedema, but you will end up with lactic acid metabolism, head pressure, all these other things which are just going to be completely preventable if you are maintaining those lymphatic vessels manually while you are sedentary. So part of the protocol involves identifying key areas, and it might be neck, occipital muscles, it can be across the armpits and the chest, and of course across the groin, where you're dealing with a lot of the gut issues. You tend to see that there's more reactive nodes around just either side of the groin and above the iliopsoas. Occasionally I see some stuff in the back of it, but no, it's mostly the neck is one of the more big issues. Once the collagen synthesis issues have gone on for long enough, if you've been bedbound or sedentary for long enough, if the shoulders are being rolled forward, you potentially have Acetaldehyde syndrome and blockages there. So that's something else that needs to be rehabilitated. This was one of my little examples of what happens in microbiome diversity. So we start off normal microbiome infection, antibiotics, second infection, again reduce diversity, and then ultimately where we end up at the end.
Yeah.
The water, of course, representing endotoxins and Acetaldehyde. The areas that we're targeting. So again, this can be any personal interface. So we're starting off with just nasopharyngeal tissue.
Yeah, got dandruff.
Yeah. Station tubes. These are all really common areas to see the biofilm build up and inflammation, sinuses. There are no figures in here at the moment, but of course, yeah, the vaginal microbiome is quite a frequent area for the dysbiosis in biofilms. The men, we also still get cystitis and bladder and even mastitis. We end up with lumps and painful areas around the nipples as well. So the biological sex has no bearing on the rate at which that happens. We're using topical antiseptics and probiotics locally delivered. So at the moment, it's just a mix of biofilm breakers and antimicrobials, antifungals, which have in the literature quite high efficacy. We've been doing very, very well with that. We're testing some other ideas at the moment, which are actually going very well. There used to be, and this one's courtesy of Gemma, I hadn't even looked at this one. And it was something my mother actually used to use when I was a kid, and then it just disappeared. It lost favor because of the concern around toxicity. So boric acid or boracic acid. And it's really interesting. It is extremely potent and extremely gentle. And yet it was taken off the market for this fear and toxicity. The LD50 is around about 350 grams. The problem is that it has, what is it? The elimination half-life, I think, is around about 5 days. So if you're using large amounts of it for a long period of time, it's actually something that can reach toxicity, just boron toxicity. But they're using it for a few weeks or something at a normal dose. I struggle to see where toxicity issues would be creeping in, and it seems to be amazingly effective. It's hitting things that some of these other products can't hit. We don't generally use the azoles too much. They tend to be a bit hit and miss with the fungal issues. MRSA, of course, is susceptible to a few things that we're using here. So of course, there's the products there, and the ratios of things that we're using to basically create these and how to apply them. We then follow, once we're breaking down the biofilms, we then actually follow with probiotics being delivered directly to those tissues. And so some of what used to be known as the lactobacillus species, so things like sake, which are found in kimchi and sake, is very, very useful as a nasal probiotic. And yeah, we're using the same thing for pretty much any of the mucosal interfaces. We then go into the environmental consideration. That's actually a big one. So there are various ways that we can remediate that. So things like ozone generators, if people are able to leave the room for a while, of course, regular, hygiene, sink washing for those, really important. And of course, checking for water leaks and windows and air conditioners. If you do not remediate the environment, you are basically continuing to get exposed to the microtoxins, and the recovery process will stall, if not be impossible. So that's something that needs to be addressed. And then, yeah, just looking at the biofilms and the way that the immune system actually can deal with these. So we're looking at things like the secretory IgA, defensins, and of course, once it gets through the epithelium, how the body's actually responding to that. It's just more just so people can get a bit of a feel for what this process is going to be like. Yeah. And of course, if there are parasites, those also need to be dealt with. Nothing like a epithelium eating worm to slow the process down. Some of the things that we've been testing out, there's some interesting ideas there. Chlorella, I think, will be in the next update. We've been using another SIGA promoter, but that hasn't been well. There was one idea I had here, and I'm actually exploring another version of this, which might make it more specific to fungi as well, but it's essentially like a Trojan horse where we get fibers and load them up with iodine and essentially allow that to then reverse the GI tract. It's mainly going to be for the small intestine, but it will reach the large intestine as well. And then when the fibers end up being broken down, it then exposes that microbe to a large dose of iodine, which potentially destroys the cell membrane or whatever it's saying. Die-off is a huge issue. So that actually has to be managed. A lot of it's the acetaldehyde, but there are options. The protocol deals with that. Pacing is just effective. So this is another one. This is one of the big fears of anyone who's had CFS for a long time. If I do too much, I'm going to end up getting worse. I'm going to go backwards. Yes, potentially. Part of that is because the activity levels ultimately drive the gamma activity. Now, if that interferon gamma activity is essentially attacking microbes at the barrier, the collateral damage that can be done to the epithelium can, potentially cause it to be the ham sandwich. So you've got the damage from the microbes on one side and the damage from the immune response on the other. So supporting that interferon gamma activity is a key part. If you're not doing that, then you can make that worse. The severity of the symptoms in this disease appear to be simply the load of the foreign proteins that are triggering the immune response, of course, the state of the barrier, and then the capacity of the metabolism to support that immune response. So the mineral deficiencies, essentially, the dietary deficiencies. Anyway, so long story short, some activity is needed as long as you're supporting the innate immune response pathways. So you need to keep them moving, and of course that helps with the lymphatic flow. So, yeah. I'll send you a copy of the PDF.
Yeah, that would be really helpful, actually.
Yeah. Slip rib syndrome. Okay, so that.
Costochondritis. Yeah. Chest pain. Yeah.
That's 100%. So yeah, with the collagen synthesis disorder, it's very easy to get a rib popping out, and then you end up with it stabbing into the sternum and costochondritis type pain. Another chest pain that pops up, and this is kind of, I think, more associated with GERD as well, is when the acetaldehyde gas from these microbes rises up and starts damaging the sphincters in the stomach and up into the esophagus. You can end up then with not just the acetaldehyde causing inflammation and lesions. When you're laying back down, you can end up with the stomach acid coming back up and also damaging the. So, yeah, I mean, and that can be referred pain, and it might feel like you're getting chest pain. Some of this stuff, of course, the pain is, the intensity goes up with the heart rate and the tachycardia. So, of course, oh my God, I'm having a heart attack.
Yeah.
It's the same old mess. But of course, you've got to always be careful, just in case it actually is. A lot of the cardiac dysregulation, I mean, once you get the electrolytes and the glycolytic and some of the other pathways working, and most of the cardiac anomalies like the long QT and the reduced ejection factors, things like that, potentially resolved there as well. Cortisol we spoke about before, and this just kind of explains a number of influences. We then collect data. The hair test, we're kind of relying on that a little bit less now. It only has a limited function. It'll show you, because it's essentially like an A1C. It's kind of like a high tide mark, low tide mark. What it will do is it will show you the available circulating metals, which are then averaged out in that section of hair. So you can't use it to actually determine any deficiencies.
Right.
What you can do, well, actually, a couple of the ones which aren't relating to that, those transporters, so things like rubidium and strontium, if you can. But any of the 9 metals which have been shut down as part of the inflammatory cascade, if they're low in the hair test, all you can say is that they are sequestered or not available. You can't actually say that they're systemically low. You need to test. We have been using something that's a bit unproven, but the data that we've been continuing to collect shows that it's pretty good, actually. Tried to compare it to other data sources. We've looked at urine excretion, serum. Oh dear, okay, fun topic. So serum minerals are wholly unreliable. It's the same with a number of the other. Once you've got chronic inflammation, what you see in the serum can be the exact opposite of what's in the cell. So this, I think, has been one of the major hindrances in understanding the syndrome. It's because you get false negatives and you're looking, oh, no, it's fine. Look at that. We've got plenty of this and zinc and this, blah, blah, blah. It's fine.
Useless. Yeah.
Yeah, do a biopsy and see what you get. White blood cells are a little bit better. I mean, you can get a bit of a feel from the red blood cells, but even then, they're subject to the same issue as the hair testing. It's just a direct result. So what we've been using is this is a company called Oligoscan, Physioquanta. It's a bit of a checkered past in some ways. And it's spectrophotometry. They bounce a commercially available spectrophotometer light through the hand in 4 places. It then returns a reflected spectra, turns that into a map of the elements, and then produces a report in seconds. Really disruptive technology. Works. There are other companies providing the same type of service, so competing companies. I'm actually running a little study at the moment comparing the providers head to head and actually just running the same scans on the same people from both providers. And there is already definitely a difference in the way that they calibrate the samples by the looks of it.
Right.
But look, the oligo scan reports, I'm quite comfortable with. I think iron possibly is optimistic. I think it's generally higher than it's like if we were to do a calculation for systemic iron, like iron transfer and saturation. I think it is generally reading higher than I would expect, and maybe it gets confused by hemoglobin or something. I don't know, but I think that's a little bit, a bit optimistic. The rest seem to be pretty good. And we can infer all sorts of things from these patterns. When you actually look at this data from these the skin minerals, and then if you add the organic acid test data, from the organic acid test data, you can predict a number of the mineral deficiencies that are going to be showing up in the mineral data. Simply because you're like, okay, well, if that thing's low and that's high, then those reactions needed zinc, and then that's likely low, or whichever we end up looking at. So what I tend to try to do is triangulate at least a few markers, so more than 2 or 4 markers, to then sort of infer that the presence of some of these other. But this data combined with the OAT is extremely actionable. I could show you if you wanted to share your OAT or something.
I'll share my OAT.
Yeah. So now for the fun part. There are currently 2 pages worth of supplements,
Wow.
plus the antiseptic. So that's page 1, and then page 2. Not everyone's going to need all of these things. It just depends on the, what the results that show up in mineral testing and other stuff. Some of the things in the OAT will be more beneficial than others. We've got some sources, local sources for certain things, but some of the probiotics, of course, have to get shipped on ice and things like that. So local sources. We then have a way to calculate the doses that we're using. We're actually looking at the moment on ways to improve the mineral absorption, because some of these things they'll absorb sublingually, they'll absorb transdermally. The oral absorption for a number of these just is not going to work because of that issue with the enterocytes and the mineral transporters. So that's, yeah, we found a number of products that just don't work very well. IVs for a number of these things are also not appropriate either. So when you're looking particularly at the electrolytes, for example, you could go and pipe a whole bunch of magnesium into somebody, and it's just going to end up going straight back out the kidneys again shortly thereafter. So one of the things that we talk about in this, there's two issues. So only really studied in plants, not so much in animals, but the silicon levels are directly responsible for some of the magnesium uptake behavior in those cells. So when you've got low silicon, the magnesium ends up being low. And of course, the ATPases and all the other, activity that you'd expect there are the other side of that. So if there's an insufficiency of ATP, blah, 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 there might be reasons that the magnesium intake is also low. Low lithium, potential rubidium, but low lithium in particular is also going to exacerbate the renal excretion of magnesium. So that competition every time there's serum magnesium elevation between the cellular uptake and the renal excretion is going to end up favoring the renal excretion. If the silicon's low, and especially with so that's part of the data collection. Diet. Okay, so what we understand is that we have an aldehyde dehydrogenase deficiency driving a lot of this. So that means that aldehydes, B6 foods, histamine, oxalates, which is not related to aldehydes, but also we know about that other issue. Those things need to be avoided. Things like polyethylene glycol, PEG, and ethylene glycol, they also get metabolized by the ADH and FDH reactions. They cause severe reactions in people. And most of the medications actually have PEG, it's in makeup, it's in all these different things, and they will have fairly severe reactions to it. I think it's possible because part of the metabolism from PEG ends up producing formaldehyde. I think it's actually possible, and I need to sort of suss this one out, but I think it could actually be that the PEG is actually acting as an inhibitor for those microbes that are producing, that have ADH and ALDH, because it essentially ends up creating formaldehyde at the site of, or in those microbes. So I need to kind of have a look at that. It might actually be various other ADH and ALDH might be appropriate, but people are going to have very, very dramatic responses to taking those things, even if it's just die off in the microbes. Foods. Anyway, so you can see that there are a number of different foods mentioned, and it could be their mineral content, or it could be for certain features. So things like the oat bran, they have certain types of beta-glucans, which then increase the secretory IPA in cells. That then decreases the amount of activity from the interferon-alpha pathway, which then means that we don't have to deal as much with some of the metabolic impairments there. Various food sources for things like silica, blah, blah, blah. NRF2, which is a negative regulator for IFN-gamma. Sometimes that can be quite helpful. So things like the broccoli sources, like sulforaphane. There's other products and things that we use, like carnosic acid. Funnily enough, smoking is another NRF2 promoter. I think that's, interestingly enough, something that people have been relying on just as a crutch to manage maybe sort of underlying chronic infection. Anyway, bromelain, again, useful for breaking down certain fibrin clots, but it does promote interferon-gamma. And then we need to get the macros overall. They need to be supporting the energy metabolism. So if the glycolytic pathways are severely impaired, then we have other options there. Fatty acid oxidation, that's probably going to be impaired because of the carnitine shuttle. The BCAA catabolic pathway, that can be impaired with riboflavin issues, but also biotin. And of course, if there's low B12, you see all these things on the OATs. And then, yeah, basically it's just trying to make sure that we have enough available substrates ultimately for energy production, whichever pathways are available, and then we work on removing the inhibitions for those pathways with some supplements. We have daily targets for electrolytes, and they're fairly sensible. show you how to calculate that from certain available over-the-counter salts and things. The targets for potassium, it's a really interesting one. Yet again, if you look at people who have low blood pressure or low sodium, the other side of that, once you see the blood pressure being elevated, it is very often that it is a simple potassium deficiency. So when you start correcting the potassium deficiency, you will see the blood pressure suddenly go back down from 140 over 90 or whatever, suddenly back to 110 over 70. Look at that. Wow. It was just purely a lack of K. So these things are actually quite important. The phosphorus, okay, back on the mineral scan, when you see a reduction of phosphorus and sulfur, it generally is an indicator for acidemia. It can be because of the altered renal functions, but you obviously need to support that by adding phosphates. But until you actually deal with the acidemia, this is going to be an ongoing struggle. Sometimes it's just the dealing with the lymphatic blockages and things like that. There can be other issues, of course, respiratory acidemia, metabolic acidemia. If they've got low chromium and vanadium iodine, things that are going to affect thyroid and glycolysis, you can end up feeling lactic acidemia, something to deal with. I think I mentioned it in one of the pages here, but something like a very small amount of bicarb away from
it. Yeah, on one of the previous pages. Yeah.
Too much is obviously not good. We set expectations for what the process looks like. So the key with all of this is understanding that there is no road back to health that doesn't include some suffering. So the immune system itself is generating most of the suffering. We die off from the microbial endotoxins and mycotoxins circulating. It's going to create some unpleasantness. And even just at a basic level, like when the tissue is healing, then inflammation is going to generate that. So any and all of these different things are going to be unpleasant, but ultimately productive in the end. And I think a lot of people, unfortunately, with this situation, because it's a natural thing to avoid pain, every single time that they have an immune response, they then avoid the things that ultimately are going to help them recover. And unfortunately, the other end of that spectrum is basically lying in a dark room eating cardboard because you can't actually absorb or suffer anything. So it's really it's basically getting the person to buy into that concept and understand that this is what it's going to look like. That said, we do some things up front to help stabilize a lot of the energy metabolism, to reduce a lot of the misery before we actually start trying to induce die-off and things. So before we even get onto the rest of the protocol, up front we start adding taurine in very high doses. The function for that is actually to promote the aldehyde dehydrogenase activity, but also it promotes the glycolytic pathways as well. We then add acetyl-L-carnitine in because we know that we have carnitine, so therefore we're now getting long-chain fatty acids transported in the carnitine shuttle. We get the electrolytes working again, and then that also resolves a number of the inflammation issues and things, and a lot of the metabolism which is sensitive to the electrolytes, and then we start moving on to the various different interventions. So we have amino acids where they are not being synthesized because of the various metabolic alterations, acetaldehyde. We then have very special forms of some coenzymes, some B vitamins and things. And generally speaking, a lot of these will end up being sublingual. It's like, okay, well, IV would be appropriate in a number of cases, but the reality is, unless they're, giving themselves IVs and IMs every day, you need a practical approach. So the sublingual sometimes, so it's the way to go. We use certain enzymes, not just as a dietary enzyme to break down carbohydrates and things that the body isn't breaking down to improve digestion. That can be very, very useful just on its own. But a lot of these enzymes will break down the carbohydrate cell walls. So we use a product there to gently start the die-off process for Candida and Aspergillus, and that's this Candid product. We then have some other things, and it's interesting. Some of these supplements you'll notice could actually increase proliferation of some of these functions. So they'll benefit from things like the folinic acid, they'll benefit from CO210, they might even benefit from some of the taurine. But the reality is that because the host system is so metabolically compromised, it's on balance. You know, at the end of the day, you still need to do it. If the metabolism is that that impaired, then it's just There are certain things that we don't do unless the OAT shows that it really is necessary. Biotin is one of those. Biotin is required for the acetyl-CoA carboxylase, ACC1, which is like the first step of the fatty acid synthesis, which is, of course, what all of the microorganisms do. Well, and also for viral replication. It's another area that I'm looking at the moment is ACC1 inhibitors, because that would be a very easy way to shut down a whole lot of this mess. Anyway, moving right along. So apart from amino acids and the coenzymes and the other enzymes, so we have, again, depending on what the OAT might look like, PQQ can be really useful for mitochondrial metabolism, but it's also really useful for dopamine beta hydroxylase, so the thing that converts dopamine to norepinephrine. Vitamin C, it's a love/hate relationship with that, because you need some vitamin C, you need enough vitamin C to prevent the collateral damage. But if there is an excess amount of vitamin C, you're also inhibiting the interferon gamma activity directly. So it's since, again, we don't have homeostasis for a lot of this stuff, you actually need to gauge a lot of that by the response to it. Citric acid can be extremely useful, but it also can provoke a very strong histamine release if you have a lot of it. You need to kind of get some of that metabolism sorted out first, so you start on that very gently. It's also good for breaking down biofilms and for preventing the oxalate crystals from forming to dissolve. Vitamin D3, really, really important. It will help reduce the sensitivity of the mineral transporters to hepcidin response, and it also calms down the conversion of norepinephrine to epinephrine, so PNT, and it also includes GLUT2 activity. So having an insufficiency of vitamin D3 in the situation exacerbates all sorts of things. DHA, okay, critical for lipid membrane maintenance, but also that's via phosphatidylcholine. Phosphatidylcholine is actually required for ketogenesis, so from beta hydroxybutyrate to acetoacetic acid. If you're low in phosphatidylcholine, then you have another backup. It does not work. Alpha lipoic acid, okay, so that's promote AMPK, which is again for mainly for metabolism, but it also acts as another way to break down biofilms. Apigenin is a very useful patch for a while. So it helps with ALDH. It also helps with preventing dopamine inhibited by P38-MAPK. It also helps modulate the tissue damage signaling, transforming growth factor beta-1. It makes a number of changes there, and it also inhibits the NADase, the kinase activity as well, which then means that we have less push towards the gamma activity and cholesterol go up. The next page has some things. Okay, so the minerals, they generally will be taken, some of them will be after food, copper and like that. The probiotics, they get added in after we've got the detox pathways and things working, because we're expecting more die-off to be generated once we start adding these things. EGCG, very, very useful for things like the cortisol metabolism. We don't actually want to inhibit cortisol too much, because it'll end up reducing the energy availability, but in the evening it can be very useful. And of course, we want NOx or NADPH oxidase inhibition, which then potentially allows mitochondrial complex 1 NADH dehydrogenase to be working. So there are a number of NOx inhibitors. Spirulina is actually very useful. Schizandra is useful, and the right dose of curcumin is useful. The very, very sharp bell curve there for curcumin. So in the protocol, at the moment, we're using spirulina generally in the morning. We're using curcumin in the afternoon and the evening, and the idea is to try to counteract ultimately multiple angles the cortisol elevation in the evening. There is something that I'm working through for the next update. We used to have berberine in the protocol. I took it out. I didn't want to take it out. It does some really useful things for the glycolytic pathway and the cholesterols. But the catch is that it inhibits mitochondrial complex 1, so it clashes with what we're doing with spirulina and curcumin. What I'm trying to work in at the moment, that's under testing, is actually reintroducing the berberine as a morning dose, which then, sure, it'll allow the bad pH pool to go up in the morning, which is probably closer to the diurnal cycle if you're doing, exertion activity and things like that, and then calm it all down again in the afternoon with spirulina and curcumin. Anyway, that's under testing at the moment, and will likely appear if everything goes well in the next update. Okay, stage 2. So we started off stabilizing metabolism, beginning the dial, and then we start really to the biofilms. So in this case, what we have here is and the alpha VPC choline, and that's also just part of the expectation that some of the choline metabolism might be lacking, and it's also dietary restrictions. However, of course, if we've got problems with the aspergillus mycotoxins, then it actually sends things backwards. So some people will need it, some people won't. Unfortunately, the mosaic diagnostics test doesn't give us enough data on that, but you could pull some other data to find it out. Okay, aloe vera may be getting replaced with the chlorella in the next update. It is potent. It does work very well. But the chlorella is potentially more effective and doesn't actually necessarily have the issue of driving up the primary sex hormone synthesis. It also, the other issue is that aloe vera potentially feeds some of the microorganisms that we don't.
Right.
So that's 6 of one, half a dozen of the other. Probably going to end up replacing the chlorella. Schizandra, okay, Schizandra is really good. Schizandra, it inhibits a number of cytokines, and the relevant ones in this syndrome. So it calms things down a little bit. It's a NOx inhibitor, and really, really cool is that it inhibits the yeast glycolysis. So what that does then is that it will sensitize those yeast to pretty much anything else that you throw at them. So if you were going to use propanol or something, so icopanol, you're going to have a better success with that. There was a study that showed it was nearly 100 times more sensitive to fluconazole, for example, with Schizandra. Very, very interesting. Now, we then take that a step further. So the undeclinic acid, and you can go larger than the doses you see there. So what that does is that forces or inhibits the life cycle, so it prevents the yeast from going to their hyphal stage. And that's important because in the yeast stage, they don't form biofilms. So if we then keep those species in their susceptible form, and then we hit them with Schizandra, inhibit their energy metabolism, make them susceptible to the other interventions, then we have a much better success rate in actually managing and controlling those species. Now, biotin, I mentioned before, that's unfortunately promotes fungal bloom really, really can. So if we don't need to add it, then we don't. Biofilm breaker, okay, really, really interesting work. So Dr. Anderson's work, he's spent probably 2 decades studying these biofilms. It's a product, it has a bismuth thiol. It's bismuth subnitrate, which has been reacted with alpha lipoic acid, and then there's also some nigella sativa, some black seed oil in these capsules. It is able to break down biofilms that NAC doesn't, and other biofilms that ivermectin doesn't. So that actually is quite a special product. However, same sort of thing, different biofilms respond to different agents. So yeah, it won't target certain biofilms that NAC will. You don't know what you're going to be dealing with, so we end up using a bit of both in this circumstance. And it goes really well in the antiseptic. Anyway, so stage 2 is just starting to wind up the immune activity after we're getting the minerals settled in. We then start adding in fulvic acid. The fulvic acid, it bypasses some of the mineral transporter inhibition, but it also acts as a biofilm breaker, and it's also really useful to detox a number of things that shouldn't be. Glyphosate. Humic acid is also good for certain things. It's for larger toxins. I think humic acid is about 1,000 times the size of fulvic acid. So depending on what you're trying to remove or transport, the other fulvic acid works very well. All right, this is where things get rough. So stage 3 essentially is driving up the immune response. So once we've got all the supporting pathways and things working very well, and we've got all these biofilm breakers going, we're at a point where the immune response can be very capable and supported. So of course, that's exactly what we do. We then throw additional biofilm breakers in. We then use a number of modulators, reishi and some beta glucans in particular. The reishi that we use, very specific products. I did some testing. We threw a number of different products through a mass spec, and there are really bad reishi products in the market. Yeah, USP ran a study, 75% of the reishi products in the market were fake. That one that we're using there is very, very good. So look right under the HPLC and the LCMS. Anyway, so that, and then we drive up more immune activity with beta glucans. So the challenge with this is psychological, because we are literally at this point driving up that interferon gamma activity. So the thing that makes you absolutely, debilitated is this interferon gamma cascade. So during this time, you are now going to be feeling like you were before you started the protocol, worse even. And so if you didn't know that, you would think that you're doing a very bad thing. That said, you still need to have an appetite for this. So if things are getting a bit much, you can back it off, you can restart it. The thing is, though, is that the immune system, once it has targets and once it has the capability, it's going to keep going for as long as it sees those targets, and it has the the cells and the metabolites to be able to do that. So you can wind things back down again by dialing back the reishi and the beta glucans, that sort of thing. But you might still have some continuing immune activity for a few days or more, while still able to keep producing those cells. Anyway, moving forward from there, we have water fasting. Water fasting has some really, really interesting things. But water fasting with some add-ons, not so much focused on like autophagy and mitophagy, like that. It's more, some of it is also to clear out the latent infected HHV. There was a mechanism described a couple of years ago where that appears to be something that is possible during this state under certain circumstances. The other thing is that by adding in high dose magnesium oxide, for example, and the N-acetylcysteine, you can strip the mucin and the biofilms that are attached to the mucin during this fast. So you're not feeding the microbes, they're starving, the mucin goes. You can over the course of a period of whatever the length that you're willing to run it, you can make a huge dent into these biofilms and this backlog. We've had one person that just did an 11-day enhanced water fast and cleared 20 years worth of irritable bowel disorder, bipolar disorder, everything else. And then, 2 years later, still no reoccurrence. He's been in remission since. It's not like he has to take drugs, supplements, anything. So it's not going to work for everyone doing that, I don't think. Although we could have a philosophical conversation about why every major religion used to have 40 to 50 days a year of proper fasting before it got watered down. I think there's something they knew that we forgot. Anyway, so that's essentially the process. The upshot of this is that the stage 2 alone, if you were doing that for long enough periods of time, you would likely get clear. It's if people don't want to wait, then you can push the immune system harder and go into stage 3 and then keep going. It really depends on the person's state and their appetite. We don't start stage 3 until the point where the data is suggesting that they're ready to start stage 3. And then, it's a bit of a process.
Well, a lot to digest. Pardon the pun. So through this. I will send you my relevant results, and if you could send me this PDF, that would be really, really helpful.
Yeah, absolutely.
Thank you so much for spending so much of your time.
Yeah, no worries.
This is fascinating, and it gives me some hope. And I have, just before we sign off, what I will do is I will also send you a chelation protocol that was recommended to me by a physician in Switzerland based on my heavy metal results. Now, the problem is I ordered this stuff and it's here. And it cost me about €1,000. So I'm a bit reluctant not to use it. But I'll send it to you anyway to see what you think. You know, because that might affect obviously the timing of the oligoscan and the hair mineral test and all of these sorts of things. And obviously what we do going forward with your protocol. So I'll send you my organic acids, my let's see, mine's going on microbiome testing, and my methylation test, and the heavy metal results. See what you think. It sounds like you need to have a period where you're not doing very much else to sort of do
Stage 3 in particular. Yeah, I mean, some people just won't have, you know, that availability. If you can set aside, we've had some people go through it quickly, you know, in a week or less. I've had other people where they've jumped in and decided to do it too quickly, and 3 to 4 weeks, and eventually came out the other side.
Right.
I've had one person who wasn't ready, didn't do the other things that happened, and they just weren't ready for stage 3, and they went backwards and they had to retry. Qualify them before you start by looking at the oat and the mineral data, so you can see before you spend any additional money. Like, oh, look at that. Yes, you've got all of these patterns. You can see exactly, and you can just literally apply the markers to the diagrams, and you can see where it's all going wrong. Oh, there's this. So you can predict the symptoms that somebody's going to have based on the markers that you see in the oat and the oligoscan.
Right. Okay. I'll have to find somebody to do this oligoscan then. I'm sure there'll be somebody.
Yeah, but the oligoscan look, it is a very useful tool. The thing that I get annoyed with the oligoscan is the fact that it's been around. It's been marketed to alternative practitioners since probably 2010, somewhere around there. And in that time, they never did the clinical trials. They never did all the things that you would normally expect to see. And then it was marketed essentially for research use only. And look, that's fair enough, you know, if you're marketing a research tool. But it's been marketed to practitioners as something that they can use. And it works. Don't get me wrong. It appears to actually work. But it should have gone through that normal process. It would be so much easier to then, you know, we could look at, you know, I think there are certain, like we found a couple of people out of a fairly large pool where they have a certain pattern showing that suggests that the calibration of the device, which works on the skin thickness, and it calculates that as a BMI calculation, age and blood type. It appears that particular cohort it's not sensitive, it's not calibrated correctly for that cohort. And it's when you're looking predominantly at extreme ends of the scale for BMI, which is why BMI is really not
not useful at all. No, not useful.
So I could see ways that it could be improved by just simply using, you know, skin fold calipers.
The lymphatic drainage. I mean, you know, the people who do the lymphatic massages. Kind of the same thing, isn't it?
Yeah. Well, the thing is, you can do, if you go off and get a professional to do it, and I'd recommend at least doing that once so that they can find all the problem spots and you can feel what's going on. Once you isolate those spots, and really it's probably just going to be the neck, the groin, and the armpits.
Using one of those massage guns. Yeah,
your massage gun works really well. That's mentioned in the protocol. And then for the neck, you can use a massage gun with just 3 fingers, and it's just drag from the occipital muscle down to the clavicle, down forward. You do that multiple times a day, and that's enough to clear that and keep the lymph moving. And it can make it like head pressure goes. Suddenly you don't.
Yeah, I've had it done once, and it's amazing. I mean, so I'll get it done professionally at least once, and then.
At least once, but yeah, just 3 fingers.
3 fingers. Okay.